Hello, everybody. Thank you so much for logging into our Focus on Glaucoma webinar for the Southeast Asia region. The webinar will be for 1 hour. The International Agency for the Prevention of Blindness, IAPB, the World Glaucoma Association, and the International Center for Eye Health, with support from Allergan, are running Focus on Glaucoma. It's a new initiative to mark World Glaucoma Week, which is from 10 to 16 March. For the Southeast Asia webinar, we have a very eminent panel. We have Dr. Rangaraj Venkatesh, the Chief Medical Officer of Aravind Eye Hospitals, Pondicherry, Dr. Nikhil Chaudhary, clinician scientist with an interest in optic neuropathy from LV Prasad Eye Institute, and Dr. Suman Thapa, Deputy Director and Head of Research and of Glaucoma Services at the Tilganga Institute of Ophthalmology in Nepal. And without much further ado, over to Dr. Venkatesh.
Thank you. So we'll quickly start the first presentation. Okay, so I'll be briefly taking you through the problem of glaucoma blindness in this part of the country and also the prevalence in India and Southeast Asia. So we all know glaucoma is the second leading cause of blindness worldwide, and more so in the developing world, like in Southeast Asia. And it permanently impairs vision in the affected eye, finally leading to a complete blindness if left untreated. So if you see the magnitude of glaucoma problem, which was around 60 million in 2010, in a couple of years from now or next year, we are going to touch 80 million. And by 2040, we are going to have close to 111.8 million. So the problem is almost going to double. So several population-based studies were done in India and also in Nepal, but by my good friend Suman Thapa. Some of the important studies to highlight are the Vellore Eye Study, which was done way back in '94, the Aravind Comprehensive Eye Survey done between '95 to '97, the Andhra Pradesh IDC study, which was done in the late '90s to 2000, and the more recent one is the Chennai Glaucoma Study, which was done between 2001 to 4, and also West Bengal Glaucoma Study, which was also done way back in the late 90s. When we see the prevalence of open-angle glaucoma in India, we all know as the age advances, the prevalence increases. So if you see the recent one somewhere in Chennai Glaucoma Study, it was somewhere 1.62 in the rural area, and as expected in the urban, it is almost double. It's almost 3.51. And the other studies show a prevalence of, the Andhra Pradesh shows a prevalence of 2.56. The Aravind study, which was down south, shows 1.7. So we understand that open angle is somewhere between 2 to 3%. In the same way, if you go to prevalence of angle closure in India, again, there are differences in methodology between these studies. So there are differences. But if you again go to the recent one done in Chennai by the Shankar Netralia team, again, we can see the prevalence increases with age in angle closure again. So with advancing age, we need to focus more on these patients. And also, if you see, there is a difference between rural and urban. Almost you see the prevalence of, so we have combined the angle closure disease as angle closure and angle closure glaucoma. So 1.58 almost doubles to 3.63 in the urban population. And there are a good number of patients who have primary angle closure suspect, who have a narrow angle, but they don't have a glaucoma as such. But this is also a big number, which is around 7% is the prevalence of angle closure suspects. So if you can roughly extrapolate this number, which is to the population, approximately 11.2 million people above the age of 40 have glaucoma. In that, if you see, there will be an additional 28 million people have ocular hypertension, primary angle closure suspect, or primary angle closures without the disease. So if you put both together, we have close to 40 million people in the population of 309 million above the age of 40 years who have glaucoma or at risk of disease. So it's a staggering number which we have to take care. both with the disease and the people who can develop this disease in the future. The other issue, when we talk about glaucoma and the glaucoma burden, we call it as a burden because it is not very easy for diagnosis. It is quite complex. We need to see the intraocular pressure, the optic nerve, visual fields, and also the angles of the eye. And mostly in the early stages, it is asymptomatic, and people are poorly aware of this problem. So if you see in the developing world like India, Nepal, and rest of Southeast Asia, 90% of the disease is still undiagnosed. And even in developed world, we know that only 50% of the cases are diagnosed from the several prevalence studies and also big studies like Baltimore Eye Survey and other studies. And the problem again doubles because there is a deficiency in training in residency. There is a lot of focus on training them in cataract surgery, but whereas the other problems, they're not much very well trained. So when we say challenges, I think the challenges are again poor access to eye care for people in semi-urban and rural areas to reach centers where there is glaucoma care. And when we talk about glaucoma, it's mainly the treatment is medications, lasers or surgery, but the medications are many of the times expensive and it is a chronic therapy where affordability and also kind of compliance to the treatment is very average to poor. And in countries where we have a very good national program, again it is mostly cataract centric even today and more focused only on the number of cataract surgeries, and nobody bothers how many patients we diagnose to have glaucoma or managed glaucoma. And finally, poor infrastructure and the training which I just mentioned, inadequate training to deal with this problem is kind of a challenge now. So we all have seen this. The prevalence of blindness is like this. Now, wherever it's a developing world or a third world country, the blindness is bloated, and whereas in a Western population, you can see the thinned down area showing the prevalence of blindness, either being cataract, glaucoma is less, and the opposite happens in the number of practicing ophthalmologists. So most of the places where the blindness is high, the number of ophthalmologists are less. So that is again a major barrier in dealing with chronic conditions like glaucoma. So I would insist that early detection is the key. So we have to diagnose glaucoma at the early stage so that we can reduce the risk of glaucoma blindness. The management can be easier and also their quality of life is preserved. And for this to be done, we have to create a lot of awareness, and also we need to see how to deal these patients in a much earlier stage so that we can combat this blindness. So with this, I finished the first part of the burden and prevalence of glaucoma. Thank you.
Hello, are my slides visible?
Yes,
Yes,
sir,
sir.
please go on.
Okay, shall I go ahead? Okay, so good afternoon, and I will present our model of care for a rural setting. So LV Prasad Eye Institute has developed a tiered structure of eye care service delivery, and that is spread across 4 states of India. This network was developed top-down approach in a pyramidal shape, but it functions bottom-up. The model strives to offer accessibility, affordability, and availability of eye care to the neediest people, and it is well accepted by the communities. The lower 3 levels of the pyramid are made up of nearly 200 permanent structures at the community level. So at the bottom of the pyramid, there are vision guardians. A vision guardian is drawn from the community which he or she serve. They do health awareness, they do community screening, and they do post-operative surveillance. The next tier in the system is a vision center network. A vision center is run by a vision technician, and the vision technician is a high school graduate who undergoes basic training in optometry at one of the tertiary centers of the network for 1 year. They do refraction, they dispense glasses, and they do screen for eye diseases. Typically, a vision technician screens about 10 to 15 individuals in a day. The next tier is composed of secondary level centers. Each center is managed by a team of 20 to 25 eye care personnel, including 1 or 2 ophthalmologists, and delivers comprehensive eye care for the diagnosis and treatment of common ocular conditions, including glaucoma, and surgical treatment for cataract. The lower 3 levels of the pyramid work as a unit. So typically about 100 vision guardians and 10 vision centers are linked to a secondary center, and this unit takes care of the visual needs of about 500,000 population. This is the list, this is a WHO list of priority diseases, and at the primary level, a screening is done for all these conditions. Now, as far as glaucoma is concerned, the screening of glaucoma is done on the basis of Goldmann applanation tonometry, peripheral anterior chamber depth for the angle closure variety of the disease, and direct ophthalmoscopy to take a look at the optic nerve. The glaucoma suspects are referred to the nearest secondary center where glaucoma is managed either by medical treatment, laser iridotomy, or a trabeculectomy by a comprehensive ophthalmologist. And the cases which are difficult to manage at this level are referred to the nearest tertiary level center. These centers are located in cities. These are photographs of some of our secondary centers. These are our high volume centers, and at each of these centers, about 30,000 patients are examined and about 5,000 surgeries are performed in a year. So as of today, we have 19 secondary centers and more than 175 primary level centers. This is our Apex Center, which is located at Hyderabad, and these are our tertiary level centers. And this whole network, this is the impact of our network over the last 20 years. So this is our model of delivering glaucoma care in a rural system. And now I would like to hand over it to again to Dr. Venkatesh for opportunistic screening.
I'm going to talk about opportunistic screening now, and then the importance of it in the next 5 minutes. So anybody who walks into our clinic or our hospital who is above the age of 35 or 40 years, I think it's mandatory to do a comprehensive examination. The comprehensive examination will include tonometry, gonioscopy, and optic nerve evaluation. And once there is a suspicion of glaucoma, I think the patient has to be referred to the next level where a detailed glaucoma screening is done. So this is what is opportunistic screening. So why opportunistic screening? We all know cataract is easy to diagnose, and also it's quite easy to manage also. That is how we are able to do big outreach and then bring patients for cataract surgery, operate on them. But wherever possible, I think we need to bring this kind of screening into the system so that whatever problem we are seeing, maybe either be cataract or diabetic related eye disease, whatever we are seeing, I think it's possible to bring in a glaucoma screening into it. And we know this condition is mostly asymptomatic, so patients present in very late stages, they don't come complaining saying that they have glaucoma unless they have an acute angle closure, which is very rare. And again, as I said before, there's a lot of awareness, which is very less. And also, if we can detect this disease early, we can preserve their quality of vision and quality of life. So this is one way we do opportunistic screening at Aravind eye hospitals across south of India. So in the base hospital, so as I said before, whoever patients who are entering into the hospital who are above the age of 35-40, we do a very detailed comprehensive eye examination. And also we target the high risk population wherever possible, especially the family members, which I'll brief you in slightly at a later time. So the other way which we do opportunistic screening is our vision centers. Again, like the LV Prasad model, we have these primary eye care centers, around 75 now. You're just seeing a video of what is happening normally in a vision center. As I talk today, every vision center sees 25 to 30 new patients, where a detailed examination is done by an optometrist, like how you see here. She does slit lamp evaluation, applanation tonometry, and sees the angle depth using the slit lamp, and then the patients are also dilated. A fundus evaluation is done, and then we use this fundus on phone, developed by a company called Remedio. So it's a very simple technology and a low cost technology to image the retina, the disc and the macula, and immediately these images can be transferred through the electronic medical record for the ophthalmologist to see on the other side. So every 10 centers, we have an ophthalmologist doing teleconsultation on a daily basis. So during the working hours, they do teleconsultation. So each one of them can do 80-100 patients a day. And they are able to see the records through electronically and also the fundus image, and then refer these patients who have any suspicion of glaucoma or manage them in the vision centers. So this is one way we have strengthened the opportunistic screening in primary level in vision centers. The other one is the cataract centric camps, which have been happening. So I'm just again showing you a video which we recently shot in an eye camp, where now we use electronic medical record for registration, and also for several entry, including intraocular pressure and fundus imaging is done. So there is a set of doctors who do preliminary examination, and again they have a handle slit lamps to check for anterior chamber, and then they dilate, and before dilatation a refraction is done to them, and the eye care tonometer, which is very reliable now, we are using in these eye cams. And then you can see this is a Bosch fundus camera, or it's a picture camera, which gives you a beautiful image of the fundus, and then it is transferred to a laptop which the final doctor has got. So when the patient is there, you have a detailed record with the fundus image. So again, where you suspect with intraocular pressure or discs, you refer these patients to the base hospital for further treatment. So I think this is the different way of opportunistic screening we are doing, and it is so important that we need to do this so that we can diagnose these patients in a much early stage and manage them. Thank you.
Good afternoon. Can you see my screen?
Yes, we can see your slides.
Okay. Good afternoon, everyone who's listening. So I'm glad to be speaking from Nepal, and Nepal being a country is slightly different because, as you know, Nepal is a mountainous country. And we have 50% of the population of the Nepali people living in the hills and the mountains. And 50% of the hills and the mountains don't have any access by road. So it's extremely difficult to deliver any kind of care. But however, we have pioneered in our country, the ophthalmic care is at its best amongst the other medical facilities. And therefore, we have been able to deliver the cataract program quite well. So the model through which we work is the community eye centers that are located in a very remote areas of the country, and then we have community eye hospitals which are in less remote areas, and there are satellite clinics, connected with these community eye hospitals and urban. And of course, at the city, we have the tertiary eye hospitals. So typically, a community eye center serves a population in remote hills and mountain districts and serves a population of about 50 to 200,000. It can even flare up to about 200,000. And typically it is run by an ophthalmic technician, and these ophthalmic technicians are trained to examine eye diseases, treat minor diseases like corneal ulcers and infections, and also refer patients. And there is supporting staff of eye health worker and somebody who sets up the clinic, etc. And but in the community eye centers that are looking at larger populations, they are run by even 2 or 3 ophthalmic technicians. And under the umbrella of the Telangana Institute of Ophthalmology, we have 18 community eye centers, but all over in Nepal, we have about 75 to 77 community eye centers that are also run by our other organizations like the Nepal Network Sun. And typically under the Telangana's wing, there are 18, and we examined in 2008 about 215,000 people, and the number of cataract surgeries done is about nearing about 4,500, a little over 4,500. Now, why I tell you these numbers is that we are, even in these community eye centers, we are being able to penetrate the rural areas and deliver care. And a community eye hospital serves a population of an almost urban area, a population of about 500,000 people. And typically, we have 3 ophthalmologists running these centers and staffed by about 30 people. And in one of our community eye hospitals, we examined in the only community eye hospital that is under Telangana's wing at the moment. We examined approximately 90,000 people and performed about 5,000 cataract surgery. But now we are in the process of building 4 more community eye hospitals because this has been a really good, successful program. And treatment and referrals, community eye centers can refer patients to community eye hospitals and tertiary eye hospitals. Cataract surgery is performed twice every year at the community eye centers. Ophthalmologists from the community eye hospital and the tertiary eye hospital travel to these community eye centers and do the surgery. And we also have outreach microsurgical eye clinics held every 2 months in the community. And most of them, the old terminology of the OMEC is the eye camps. And most of them are held in the community eye centers, while some of them are held in very remote areas that have even less access to even the community eye centers. And screening for cataracts are done on a regular basis by the staff of the community eye centers. So now, taking advantage of this community eye center and this model, then we started thinking, how do we screen for glaucoma? Now, as you know, as Venkatesh has said, that it's a very difficult, glaucoma is very difficult to detect, to treat, and Nicola showed us a wonderful model, but we are still at a very initial phase here in Nepal. And we believe that it has to be an opportunistic screening. It has to be piggybacked with a population, with the cataract population. When people come for a cataract clinic, maybe we look at the optic discs. So what we believe is that screening by the appearance of the optic disc is most important way to screen for glaucoma, looking at optic disc changes. And at this moment, focusing on people who will potentially go blind in their lifetime by examining optic discs which are advanced, like a 0.8 or a 0.9 cup, or a pale disc or something like that, is able to do. And less frequently measuring the intraocular pressure, because we know through most of our population studies that have been done in India, the 4 that have been mentioned, 4 or 5 that have been mentioned by Dr. Venkatesh, and the one that we've done here is that intraocular pressure is most of the time found to be normal, even in patients diagnosed with glaucoma. But however, for primary angle closure glaucoma, there are obvious changes, like maybe acute changes. And in Nepal still, we have patients with acute attacks that come to us, and there's sequelae of these angle changes that once we see them, then we are able to refer. So at the community eye center, the first point of contact for a patient is the ophthalmic technician. And the ophthalmic technicians are trained at using the slit lamp, are trained at taking the intraocular pressure by using an appellation tonometry, and are trained at are looking at the optic disc for a 90 diopter. Now with the incorporation of a portable camera in the system, we have been able to use teleophthalmology that has helped in case detection. So the challenges and obstacles that we see is that in the initial days, an ophthalmic technician used to, in the earlier days, the ophthalmic technician used to look at the optic disc with the direct ophthalmoscope, and any optic disc that looked like that appeared somewhat glaucomatous were referred, and the patients had to walk several days, where there are no roads, people have to walk, and then they take a bus ride, and it even takes like 6 to 7 days to come to the tertiary hospital. So there were a lot of false high positive being referred by ophthalmic technicians. And even and with now what we have found is that even when detected, treatment is expensive and unaffordable. In our country, we don't have any programs by the government to cover the expense of treatment, or even programs that are helping awareness. So, and we know that the advanced cases that have to be treated immediately, they have to be referred, and patients have to travel to the community eye hospital. So these are just the obstacles, But the strategy is that when we have used teleophthalmology, it has decreased the false positive cases. These patients who would have otherwise had to travel several days are now not traveling and are being sent back home right from their first point of contact. And screening by examining the optic disc by an inexpensive portable device is the way to go. We have been working on some devices, we have been validating them, we are on trials of seeing which is the best device used in our community. So I will talk about that in the next presentation. And if they come to the tertiary hospital, we are providing subsidized or free treatment through cross-subsidy, through all the money that is generated through the profits from the cataract programs can be used to help patients with glaucoma. So this is the end of my first presentation, and I look forward to your comments, and I look forward to the second presentation. Thank you.
Good afternoon again. Can you hear me and see my slides?
Yes, please.
Yes, we can. Thank you.
Okay. Good afternoon, Dr. Venkatesh and Dr. Suman and everybody. Now I will show you another model that we have recently working on, and this is our pyramidal model. This has established well over the years. The lower three levels of the pyramid, they function as a unit, and the difficult patients are referred to a tertiary center. However, we realize that there are a significant number of patients who are unable to access tertiary care, and this is for various reasons like their systemic health or financial reasons or not having sufficient support. So then I thought that we should add a top to bottom stream of care to these centers, and as an experiment I started visiting one of the 4 selected secondary center every week. So I spent 2 consecutive days at a center. I examined patients on the first day and perform surgeries on the second day at the center itself. So this initiative of combining a horizontal stream of care and a vertical stream of care is constituting a diagonal model of glaucoma care. I thought this because most of the decisions in glaucoma are clinical and the newer imaging modalities are necessary in only a few patients. So in a good cataract setup, if we add a visual field analyzer, we can take care of majority of the patients with glaucoma. Trabeculectomy surgery can be performed in a cataract setup, Thus, a significant proportion of patients with glaucoma can be managed at a rural center. So first of all, we charted out an approach for patients who are suspected to have glaucoma. The ophthalmologist performs comprehensive eye examination as explained by Dr. Venkatesh also, and a laser iridotomy is done on patients with narrow angles because there are ophthalmologists in the secondary centers, and the findings on optic disc and visual field examinations are classified. This leads to stratification of severity of the disease, and the classification is also based on the risk of blindness. Now the patients are managed as per their strata. So the patients who fall in category 1 are primarily managed by the ophthalmologist, and some of the patients of category 2 are also managed by the ophthalmologist. Whichever patient the ophthalmologist has doubt and they fall in category 2, or all the patients who fall in category 3 are scheduled with me. So I examine them on the first day of my visit and operate them on the second day. I identified a simple book of glaucoma. This book is made available to the ophthalmologist at the secondary center. And in my visit, I also get a chance to take classes, answer doubts of the ophthalmologist on 1:1 basis. So this is an example of targeted learning. And I can teach surgical procedures as well. Now I will show you some of the illustrative cases like this. This is an elderly gentleman who presented with advanced cataract and very high intraocular pressure. He was operated at the center itself, at the secondary center itself in the rural, and he achieved a good visual recovery. This poor lady came from a small village and she had acute angle closure and nanophthalmos, a difficult case, but again could be managed. This was another monocular patient who had a bleb leak, and fortunately I could deal that with autologous blood injection in the center. We also make efforts to increase patient awareness. So simple measures like explaining usage of drops by a trained counselor or playing educational videos in patient waiting lounges do help. With time I realized that trabeculectomy combined with a manual small incision cataract surgery is an optimum surgery to treat the often coexisting glaucoma and cataract problems in rural areas. So I have developed a fixed surgical formula to ease the learning curve, especially for a comprehensive ophthalmologist. And this is the outcome of the formula of the surgical technique. It results in a shallow diffuse bleb. And this is the surgical outcome of a surgery performed by a comprehensive ophthalmologist at one of our rural center. This is the interim analysis of a project that is looking at the outcomes of this particular surgical technique. I also recently looked at the patients which are treated under this diagonal model. So we took 231 new patients, means those patients were diagnosed to have glaucoma for the first time at the secondary level center. We do have a large pool of chronic glaucoma patients, but this study included only the new patients, and 60% of those patients were elderly and about 20% were monocular, and about 35% patient fell into the highest category of glaucoma severity. Now about 25 to 50% of glaucoma patients earlier were needed referral, but in this model all the adult patients were managed at the rural center itself. The outcomes were comparable to our center in the tertiary care or apex center. It has increased the case detection rate, especially of the angle closure variety, and I needed to contribute to as many as 50% patients, and I also used the opportunity to train the ophthalmologist. Basically, glaucoma can be managed with few additions to a cataract setup, and if a glaucoma specialist travels 2 days in a month, like Dr. Suman was also elaborating, then we can make a significant difference to the patients who are in rural or underserved regions. And there are some advantages of glaucoma in that sense, which makes this possible. This kind of model has worked for cleft lip and cleft palate repair, and I think glaucoma is the next specialty where it can suit well. So therefore, I think this model has a potential for wider applicability, and I would like to conclude here and hand over to Dr. Venkatesh.
Thank you, Nikhil, again for bringing out your diagonal model. I'm sure it'll have a very good impact, not only for the patients, but also, as you rightly said, for the training. It gives a lot of confidence for the ophthalmologists who are working in the secondary care centers. So they get very well trained to manage glaucoma. So here I'm going to share another interesting model of family screening, because I think we need to really target the high risk groups. We can do a good opportunistic screening, but the yield will be very high if we can do this family screening as a routine practice. So I'm going to share how we are doing it for the last 4 or 5 years. So we have been seeing these are the different ways for screening. One is mass screening, which is very, very difficult unless we piggyback on other screening like cataract or DR screening. And then you have opportunistic screening, which again we discussed, where we do a comprehensive evaluation for somebody who walks into a clinic or a hospital for eye examination. And then I think the most important, which comes in the center part, is the high risk screening, and screening of those who are really at high risk. So population-based screening, again, there is a limit to the glaucoma detection, and also there is a lack of specific and a very sensitive test to do it. And it is not cost effective. And many of people have tried and they have given it up. So considering other risk factors for screening like race, ocular biometry, genetics is again challenging. And this family screening definitely has got a very good yield. An appropriate treatment and follow-up of such individuals is likely to prevent needless blindness because of glaucoma. So from several studies in the literature, we know that family screening has got a very good yield, from somewhere from 10 to 20%. And if you see, the siblings are the most highly affected. In Rotterdam study, you can see 10.4% of siblings have been affected with glaucoma. And in Baltimore Eye Survey, again, close to 10%. So if we can really get the siblings for screening of our primary or the proband, it will be really good. So even in India, I think there are several studies, including the one which my colleague Dr. Kavita did sometime back on angle. A PACS siblings of primary angle closure suspect had 30% risk of primary angle closure suspects and almost close to 5% risk of having a PAC-PACG. So even if you see a PACS, if you can invite their siblings for screening, you can definitely avoid blindness because of PACG. And when we saw the siblings of patients with the disease, so we combined again angle closure and angle closure glaucoma together, the PACS was 25.3% and the PACG was high as expected, almost 11.4%. So again, by just seeing the siblings of suspects and angle closure glaucomas, we can prevent a patient getting this disease. Because in this problem, I think we have a very good treatment in the form of laser iridotomy or even a early cataract surgery can totally prevent the disease in these patients. So I'm just briefing you how we do this. So one is opportunistic screening, case detection, and then you initiate treatment on them, and then you apply the formula of family screening for the newly diagnosed patients with primary glaucoma, either an open angle or an angle closure. So this screening we again do in base hospital in some of our secondary eye care centers and also in our vision centers. Again, I'll just show you a quick video of how this works. So this is when a patient is diagnosed to have glaucoma, a detailed case sheet is filled, which is called a glaucoma folder, where we take details of how many siblings, parents and children. And then the counselor also discusses with them, and then she issues a family screening card like this with a proband name and who is the relative who is going to bring the card with them. And this details are entered into a software which was developed by the team at the IT team at Pondicherry and also incorporated into our electronic medical record now. So this software will have details of all his siblings, if they have children above the age of 35, 40, or if they have a parent who is still living. So they take the details of that, and then we take their mobile contact numbers also. So a automated SMS is generated which says that, no, your brother had glaucoma, can you kindly come for an eye checkup, and some details about glaucoma is given to them. And then if they bring the card with them when they come for checkup, they are directly seen in the glaucoma clinic. They can bypass going to a general unit. And by this software, we are able to regularly access and see how many family members came for screening, and then how many people are yet to come. So sometimes if like a World Glaucoma Week or a month we celebrate, we even call them and then remind them about this. So in addition to sending SMS, we also invite them over a phone call to make sure they come for screening. So just to show you what happened in the last few years, close to 900 to 1,000 patients of the first degree relatives of the patients were seen, and the patients with glaucoma or some suspicion of glaucoma, if you see these are the numbers, and roughly somewhere between 15 to 20% we can pick up in this group. The yield is really high when compared to the prevalence of glaucoma in a community, or the problem of the patients who are coming for regular eye screening. When it comes to family screening, you can have a very high yield. There are few suspects in this, but still it is worth following them to prevent any vision loss because of glaucoma. So we do this actively in our tertiary care centers, in our secondary care centers, in some of the outpatient clinics which we have, and also we try to do this activity in the month of March, like when the World Glaucoma Week comes. We encourage some of the members to come to our primary eye care centers to again break the access and then make sure they come to a nearest center where our ophthalmologist or a glaucoma specialist go and do the family screening. So these are some of the locations of our main centers and the vision centers. So we are able to quite comfortably cover the state of Tamil Nadu and Pondicherry to a great extent. And soon we'll have some centers around our hospital in Chennai and Tirupati, which may cover some of that geographical area. So this is one way we are kind of really targeting the high-risk group, which is the family members of primary glaucoma, either be open angle or angle closure. The yield is very high, and definitely we can diagnose disease at an early stage. And if we can diagnose early in cases of angle closure, we can even prevent them from getting a glaucoma. Thank you.
So the newer developments. So after we conducted the Bhaktapur Glaucoma Study, what we realized was that most of the patients who had glaucoma had changes in the visual field and the optic disc. So clearly, what it pointed out to us was that we should be looking at ways in how we can look at the optic disc and do visual field to find visual field defects. And if we're able to combine these two, then the specificity and the sensitivity of case detections would be much higher than just doing one, but just by doing one. And if it is combined with the clinical examination, obviously it would be better. So in that process, in our journey, what we did was that we compared an iPad Visual Field Easy app that was created by Dr. Chong, who was a medical student at the University of Melbourne, And he had put it up as a free app, and somehow Chris Johnson, who was working on visual fields, he was able to find this app. And I had these serious questions in my head, and I met up with Alan Robin in one of the meetings, and he said, hey, why don't we just try and see what we can do? So because from the findings of the Bhaktapur Glaucoma Study, it was a big concern for me. And then we collaborated, and then we validated the free app on the iPad visual field with the Humphrey visual field. And we realized that it was very good in detecting moderate to advanced glaucoma cases, but it was not good at detecting early cases. There was a lot of noise in the field, and but our entire goal was to look for advanced to moderate to advanced visual field defects. So somehow it was fulfilling it was answering some of our question. And at the same time, then we said, okay, let's look at the optic disc and what is the best way. And then there was the picture. And with the picture, we worked with Aravind as well with Dr. Venkatesh and Alan and I, and we started, saying, yeah, let's try to, validate this. And it happened here. And we compared the photographs taken by gold standard TopCon tabletop, which cost thousands of dollars, against photographs taken by the picture, and we realized that they were also very comparable. And the advantage of the picture was also that we were comparing these photographs through an undilated pupil, so like in a real setting. So it was very promising again. And then we tried to combine these two techniques, and then we gave it to an ophthalmic technician, and he went up to the mountains and did it. But unfortunately, the study was abandoned because of the earthquake. So everything was derailed for a year, and that was what happened. And then we moved on. But then, as we were moving on, what we found that maybe there was something else that was more portable, that was much cheaper, and than the picture, and it was something known as the Paxos. Now, the Paxoscope was developed by some scientists at Stanford University, and while we were visiting there, and we spoke about trying to get this, and the Paxoscope had already been validated, and we thought, why not we see how it works in Nepal? So with a startup company in Stanford, we were in San Francisco, and with the scientists in Stanford, they developed a mobile app in which the photographs could be taken, the anterior segment photographs could be taken, the optic disc photographs could be taken by this apparatus that went onto a phone, and then by putting a 20 diopter lens, and by taking the photograph, then we could actually enter the data of the patient, and we could send it out from the periphery, and it could be visualized by an ophthalmic technician right there in the field, and it would come up as a notification, just like in any of the other apps, like WhatsApp or Facebook, and we could see the photographs. So this was even much convenient because it was portable and it was much cheaper, and at the same time it could be put into a pocket and it could be moved around. So that was what we did, and we did some studies. I'm sorry, so this is just a publication we have, just for your information, a publication that we had, Victor versus the TopCon, and also the publication that we had in 2018, I guess, yeah? And about 2017, sorry, about the iPad versus the HM. So you can read these articles and see how we worked on them. And like we said, in the meanwhile, we moved on to the Paxos, and we have been, we are now, we did take the Paxos out in the community eye center, and then we gave it to an ophthalmic technician in the community eye center, and we did a blinded study where the ophthalmic technician was first looking at the diagnosis through a slit lamp and a 90 diopter examination, and was marking a diagnosis, and then after that was taking a photograph. After that was taking a photo with the camera and was sending it over here to ophthalmic to an ophthalmologist here at the tertiary center, and we were doing a comparative study to find out whether there were any cases missed when they just examined through a slit lamp, or was just by taking the photographs by a handheld camera, they were able to detect even more. And what we found was that when they were doing a clinical examination through a slit lamp and looking at a 90 diopter, there were in fact missing cases when they're missing cases, and their detection of cases was actually much better when they just took a photograph and then they evaluated the photograph. And most of the cases that were missed were cases of glaucoma, cases of diabetic retinopathy, etc. So in many ways, it looks like if they did have something, a photograph, it would probably be better. But of course, when we combine the clinical examination along with that, measuring the intraocular pressure, then I get the specificity increases. So we are all working around the bush to find a way in which how we are able to, find the best way in at least at the moment referral. And it was very interesting what Nikhil said about the way in which the SICS could be combined with the trabeculectomy and the way of doing it. My concerns are that in countries like in Nepal, where there's so much ankylosing glaucoma, so much inflammation, that things fail so easily. And but for the fact that cataract surgery is done in high volume, so that itself may be a therapeutic measure for ankylosing glaucoma. But what you have said is very interesting. And now we are working on something which is known as a Toronto portable perimeter, and this actually is a visual field that is thresholding. The defects is they are using a way of not only detecting a defect but also trying to quantify as to how much defect there is in glaucoma. So I think this is going to be more interesting. This instrument has not been validated, so we are trying to work on validating this. So this project is going to start this year. So at the World Glaucoma Congress, we'll be again brainstorming, putting our heads together to be able to find something which is more accurate. And we hope that by using a portable camera, there are so many models of portable cameras, and we just need to find the correct way of detecting a visual field defect. And if we are able to make a patient undergo a visual field defect, undergo these tests, which will be able to find defects and to increase the specificity and sensitivity, I think we will be able to at least talk more about opportunistic screening in places that is much further away from just our community eye hospitals and tertiary eye clinics. And again, so this is some of the Paxos publications that we have had. We have done some work comparing the quality of photographs, and there was a poster presentation by our group at the AO in 2018 about how referrals are being done and what we think about it. So I think this is the end of my presentation. I'm very thankful for all of you for inviting me and to be able to represent our small country, which has enormous problems in detection. And I hope you've had a great 1 hour of conversation from our side. Thank you, Emma. Thank you, Nikhil, and thank you,
Thank you, Suman, for highlighting some of the we can't say low cost, but these are all technologies which are kind of game changer, for our outreach work. And in difficult terrain, taking some of the equipments are impossible. You can't take a higher end fundus camera or a visual field analyzer. So we need to look for low cost technologies at the same time which are validated, and also we need to see how we can use this for better screening and detecting glaucoma at a much earlier stage. So Nikhil, we have a few minutes left.
Yes, yes.
Yeah, we don't have much time, so maybe we can do a discussion for a couple of minutes. And I think there's only one question that I've noted, but
Okay.
after your discussion, perhaps.
No, I think we can take the questions because we are running short of time. People may close. So, what is that question?
So the question was, how can medicines like Exforge, and I'll try and pronounce this, amlodipine valsartan, affect glaucoma medicine in general?
I think we are all anti-hypertensives. So what we understand from evidence and what in our practice we antihypertensives at night can cause hypotension. So we ask them to take antihypertensives at daytime because nocturnal hypotension is not good for somebody with glaucoma. Now it can compromise the optic nerve head blood flow and it can damage or worsen the glaucoma. So especially in normal tension glaucomas where already the optic nerve head blood flow is compromised, we ask them to avoid taking these tablets somewhere after evening. So it is better to take at daytime. Nikhil, you want to add anything on that?
Oh, nothing. You have well summarized the issue. One
Uh,
thing that
Please go on.
if we have a beta blocker versus say ACE inhibitor, the beta blocker itself may function less because the receptors are suppressed, but an ACE inhibitor may go unopposed and may increase the chance of nocturnal hypotension, is what my understanding is.
Okay. So one question to Suman. Suman, that Toronto portable perimetry, is it a supra threshold or a threshold?
It's got both. So that's
But
the interesting thing about it. It has, like for example, the iPad Easy had only a supra threshold, but this has got a supra threshold as well as a threshold. So so we'll try to find out exactly how both programs will help in detection.
yeah, the best part is it works on virtual reality, so that there are certain advantages of doing a VR perimetry. So you don't have to occlude an eye. Automatically, you can occlude a eye and a visual perimetry. And again, you can do it anywhere. See, when we are doing an iPad or a Dell-based, tablet-based visual fields, there are a lot of external disturbances which can make the patients uncomfortable in doing a visual field. So a virtual, a VR perimetry, you can do it in a campsite, you can do it in a atmosphere which is not very conducive for it.
Right.
We are, Nikhil, you want to ask any last few questions before we?
Okay, I am interested in knowing how the strategy of family screening is very good strategy. So I am interested in knowing how did it evolve? The software that you made and the whole program that you made, how
Yeah,
has it evolved?
that's a good question. So it's something, something which, like how you are passionate of the approach. So I keep seeing families or big families with glaucoma, and every one of us see, including Alan Robin, when he saw a big family, they worked on it to find even a gene behind it. So when I was seeing these families, I was thinking, what's happening? We say we need to strengthen family screening, but we are not going to the next level. So what do we do? So that is where we thought, why don't we introduce something like incentivization, giving a card to the proband and asking him to give this card to his sibling and motivating him to come for a screening. So the motivation on one side, and if they bring the card, we used to exempt the consultation fees for them. So that was another incentive, and also the patients used to be screened directly in the glaucoma clinic so that they don't have to go to the general unit and waste time there. So these are the two ways we incentivize this motivational card, and then we saw a good number of siblings, mainly the brothers and sisters of the patients coming for screening. And this gave us an insight that we should keep working more on this, and that's when we started the Indian Family Angle Closure Trial also, which was quite successful. We were able to comfortably recruit the siblings for the study. And when this became a regular phenomena, we wanted to develop something like a software which can again give us updates of the family screening and also generate an automated message, because reminding the family members is critical. So when we started talking with few people, they said, why do you worry about my brother and sister? No, I don't have any, we don't talk with them much. No, it's becoming a generation like that. So we thought, even if you are not talking, you just, if possible, you give their mobile number, we'll send an SMS, an alert at least, saying that you need to have a family screening. So that's where we wanted to collect their contacts also. From the giving just a card, we wanted to collect the contacts. So we had to put these contacts somewhere so that we can kind of optimally utilize it. So we developed this software in a small level at Pondicherry, and then the team at the Madurai IT team helped us to kind of now incorporate this and make it better into our electronic medical record. So this is just a brief history of the family screening.
That's fantastic.
Nice. It's very impactful. Very nice.
So easily we are able to see, now we are seeing close to 150 to 200 family members in a month. So roughly 1,000 to 1,500 patients in a year, like 10 active months if you take in a year. So you are able to see 1,000 to 1,500 family members. And if you see the yield of glaucoma, it's really high. It's 15 to 20%, as I said before. Many of them have glaucoma and a lot of suspects, but still, if they are suspects, it's good to kind of counsel them about annual eye checkup, because one of our family member had a glaucoma. And the other thing is, wherever we have seen a family member blind in one eye or have a very poor vision, we see the family screening more effective. In the meaning, the rest of the family, when they tell, this is your status, the family screening is really effective. No, but we don't want that to happen, but this is one observation which we are seeing. So wherever a member is blind, or his father is blind, a mother is blind of glaucoma, the family screening is very, very effective.
Thank you so much, all three of you. Thank you so much for your time. I think we've completely run out of time now. So before I suggest we end the webinar, a small reminder that they will be sending out a survey that will be coming out via the GoTo webinar system, and it'll not take you more than a couple of minutes. Please fill in the survey to tell us how you've found this webinar. And with that, I think we should call it a day.
Yep.
Great.
Thank you.
Thank you so much. Thank you, all of you. Thank you so much, everybody, for attending, and have a nice day. Bye-bye.
Thank you.